Hello, and welcome to chapters 13, 16, and 20. I am sure you are absolutely thrilled that we are done with all of the growth and development sections and we are moving forward. Now, don't get me wrong, you will still see some growth and development milestones within these chapters following through the rest of the semester, but it will not be as much content as we will now focus on other areas of the pediatric client. So, the first chapter we will talk about is chapter 13, which is the child and family communication. Then we will look at 16, which is care of children who are hospitalized. And lastly, chapter 20, loss and bereavement. I want to note that these three chapters may be a little long for you to listen to all at once, as I will do them all together. If that is the case, please feel free to break it up and come back and review at your leisure. And if you have any questions, comments, or concerns, they will be able to be answered within class on next Thursday. So, with that said, we will begin chapter 13, which is child and family communication. When looking at the child and family communication, the ability to communicate effectively is a basic and central component in delivering care to children and their caregivers. Enhancing understanding of a child's health condition can reduce the fear and pain, as well as encourage active participation in the care plan decisions. As authentic, non-judgmental, empathetic manner improves not only the quality of care, but also determines the success of relationships established in delivering that same care. When we look at the process of communication, you want to note that communication is defined as the exchange of meanings between and among individuals through a shared system of symbols. The sender generates a message in response to a need to relate to others, to create meaning, and to understand various situations. The message is either verbal or nonverbal stimulus produced by a sender and responded to by a receiver. The channel is the medium through which the message is transmitted. It may be visual, auditory, kinesthetic, and you want to note that visual channels include sight, observation, and perception, whereas your auditory channels include spoken words and cues. For your kinesthetic channels, these include sensations, experience, such as that of touch. The receiver is, of course, the person interpreting the sender's message, and feedback provides the sender with information from the receiver about that message. Communication is both talking and listening. The ability to prepare and present ideas, feelings, and thoughts accurately by talking and responding to messages accurately by listening reduces distortion and results in, of course, effective communication. When we look at barriers to communication, these may be physical or psychological factors. The physical or environmental factors include the physical space or distance between the receiver and the sender, the temperature or ventilation in the environment, distracting noises such as that of the radio or television, or patient's health status, especially if the child or family is disoriented or has a hearing or visual handicap. Psychosocial barriers to effective communication include one's personal judgments, past experience, emotions, developmental level, social values, or perceived power differences between the sender and the receiver. Allowing feelings or preconceptions to influence behavior, opinions, or beliefs may also be problematic. Personal opinions need to be carefully shared with children and their caregivers because nurses represent authority figures. Even facial expressions that convey disapproval may become a psychosocial barrier if the child or family does suspect disapproval. There are different modes of communication. Formal communication refers to communication that occurs in an organized way with a particular agenda, such as when teaching a child's care to the caregiver upon discharge. Formal communication must be clear and, of course, understandable. When we're looking at informal communication, this occurs when individuals talk using no particular agenda or protocol. Often, informal communication occurs sporadically when caring for children and their caregivers in day-to-day interactions. Your verbal communication refers to messages that are communicated through words and, of course, language. It is most effective if it is brief, clear, effectively toned, paced, appropriately relevant, and, of course, well timed. Messages should be sent at the appropriate time. For example, teaching will not be effective if delivered when the children are in pain or have lots of visitors. You want to look at the paraverbal cues, also a part of verbal communication. These include the tone and pitch of the voice, volume, inflection, and speed, and grunts or other vocalizations not considered language. Your nonverbal communication, on the other hand, conveys feelings, attitudes, and intentions. It enables one to interpret verbal communication and transcend the literal content of the message. The nonverbal communication is especially apparent when emotions cause observable body changes and comes through more powerful and effectively when there is incongruence between the verbal and nonverbal message. In fact, most communication is nonverbal, and most verbal communication contradicts the nonverbal message. Listeners will believe the nonverbal message rather than the verbal message if they do tend to contradict each other. Your nonverbal communication includes spatial relationships, which is the distance between participants, appearance, the clothing, grooming or hairstyle, eye contact, body posture such as slouching, standing erect with the head leaning toward the receiver, gestures, which can sometimes add emphasis to words, facial expressions, which need to agree with the same verbal message, timing, such as hesitation, may imply untruthfulness or diminish the effect of the message, and with children especially, touch. Touch may be one of the most important communicative behaviors nurses can use because to many it conveys empathy, warmth, understanding, affection, willingness to become involved, as well as nurturance and caring. You want to know that the benefits of therapeutic communication is that it leads to increased knowledge and healthcare behaviors. Hence why we stress partaking in therapeutic communication. And you may have covered this as well in mental health. Therapeutic communication is key, and that is also true when it comes to pediatrics and their caregivers. And like your book was saying, oftentimes nonverbal communication contradicts our verbal communication. So we really, really, really must be cognizant of our verbal and nonverbal communication, because what we don't think about is our facial expressions, our gestures, maybe our eye contact, and it may or may not be a cultural thing, but it will say something to the receiver of the message if you are contradicting yourself with your nonverbal behavior versus your verbal communication. Alright, let's look at the nurse, child, and family communication. Nurses always need to be aware of client and family needs for education and use communicative interactions as an entry into providing new or reinforcing old information. Before communication can be effective, several key elements must be addressed. These include building rapport, trust, showing respect, conveying empathy, listening actively, providing appropriate feedback, managing conflict, and of course, establishing professional boundaries. First, we will look at rapport and trust. Nurses must develop trust and rapport with clients, and the clients must be willing to talk, listen, and provide honest answers. Nurses may also need to be available and open to questions caregivers and children may have. To build rapport with the child and the caregiver, the nurse must be accepted by them and willing to discuss non-health related issues to convey warmth and, of course, friendliness. To establish trust, a nurse must follow through on promises, keep appointments, respect client confidentiality, and carefully explain any procedures in a way that is acceptable for the family. When we look at respect, to establish this, the nurse should address the child by their first name, which is the formal name, unless given permission to use their nickname, and of course address the caregivers by Mr., Mrs., or Miss, and then the last name. Nurses need to convey that they have time to spend with both the child and the family. This will allow the family to share thoughts and concerns and also ask questions. If the nurses non-verbally communicate that they do not have time, for example, by standing by the doorway or frequently looking at the clock while talking or confiding to the child and the family how busy they are, caregivers and children will soon believe that the nurse is too busy or either doesn't really care. You also want to remember that smiling is important. Although the child may not see a smile from the nurse's mouth, if it will be covered by a mask, the child will see it in the nurse's eyes. So this is important. When we look at empathy, this refers to the ability to put oneself in the other person's shoes, to feel as well as to intellectually know what the other person is experiencing. Empathetic nurses are able to appreciate and understand children and caregivers as unique individuals and allow them to feel cared about and accepted. The empathetic nurse maintains a sense of objectivity and is supportive, understanding, and able to plan and implement helpful behaviors by teaching and giving examples that facilitate the ability of the child and the caregivers to function in difficult and sad situations. Listening, very, very important. This consists of providing both verbal and nonverbal cues that communicate interest. One not only listens to the words of the child and the caregivers, but also to how the words are used and decides whether what is said is really what is meant. Accurate listening does not happen without effort. It also includes maintaining eye contact, taking an open and relaxed posture, and facing the child and or the caregivers. You do want to note that some cultures do not agree with eye contact, so do not take offense to this if that is their culture and they do not maintain eye contact. However, remember, giving and receiving, like I said, is a cultural behavior. When working with children and caregivers, the nurse should encourage and allow each to give their input, discuss concerns, express feelings, and acknowledge any problems. While listening to children, the nurse must consider their developmental level, cognition, and emotional behavior. Nurses should also developmentally use appropriate language and behavior with children and attend to their behavioral cues for clues as their concerns and fears. Therefore, when a child is expressing fear, listening skills are key. You want to sit at the child's level, nod in response to the comments that the child makes, and maintain eye contact while the child is talking if it is culturally accepted. When we look at providing feedback, this can include nodding of the head, reflecting back to the client, what was said, asking questions to clarify, seeking validation from the client to ensure when it's talking about the same thing, and focusing on a single idea and exploring it further. When providing feedback and teaching, such as educating about blood pressure and how it should be within the range or below 120/80, you want to talk about such things as diet and exercise in an effort to lower the blood pressure and the risk for hypertension, especially in the teenage years. This is when you are being that educator. You're going to be providing feedback to both the parent and the child. Also, we want to look at, we're going to skip over conflict management and we'll go to professional boundaries. The nurse should create and maintain professional boundaries in relationships with children and their caregivers. Therapeutic relationships should be caring and empathetic, but should avoid emotional over-involvement and overprotectiveness. It is always helpful to explain to children and families the type of care to be provided, when the care will be provided, and how both parents and children can assist in their plan of care. The nurse should never interfere with the relationship between the child and the caregivers. Rather, the nurse best serves the child by assisting the caregivers in caring for and nurturing the child, and by recognizing the need of the caregivers to feel accepted by the professionals and to be recognized as important to the child's well-being. Finally, nurses should avoid personal behaviors that signal over-involvement, such as socializing with the child or their family, sharing personal information such as home addresses or telephone numbers, and giving or accepting gifts. This is a no-no when it comes to communicating with a child. We never want to cross those professional boundaries. And a lot of times parents will feel like they are not accepted, or as if their input isn't valuable. But as the nurse, you want to make sure you let them know that their input is valuable, especially for a smaller child. Even with your teenage kids, their input is valuable, and you don't want to overstep your boundaries or become over involved. You should not be accepting gifts. You should not be exchanging telephone numbers. And I know this can be hard, especially when you start dealing with the terminally ill and they are in your care for long periods of time. You have to learn to separate yourself. So you do want to look at the family teaching box on page 415 in your text that talks about resolution through communication. Of course, you want to actively listen, clarify points of difference, take each other's feelings seriously. You also want to generate alternative solutions together, and of course negotiate the solution. This works for all children, of course, if they understand and can communicate with you as the nurse. Then you always want to employ therapeutic communication. Looking at some of the additional skills used in communication or that are useful in communication is observation. Observation skills enable the nurse to validate and interpret what children and caregivers do not actually say. Nonverbal behavior provides meaningful information about what the child and or the caregiver is communicating to each other and to the nurse. Congruence between the meaning of words and all other behaviors validates this message. Cues also need to be interpreted from within the child's cultural perspective to avoid erroneous interpretations. And this is when being culturally aware and competent comes into place. Silence is another one of those useful skills. This may be another method of communicating or used in effective communication. Silence should be interrupted in relation to the environment where communication occurs and the normal behavior of those interacting. When we look at the environment, this also plays a vital role in effective communication. It can affect the communication between the nurse, the child, and the caregiver even more than the spoken words. The way the nurse exists in the environment and use the space to make people more or less comfortable as they seek care is important. For example, we talked about that just a few minutes ago with the nurse standing at the door, fidgeting, looking at the clock. You can make the caregiver and the child's environment very uncomfortable so they will not communicate with you effectively. Also, if the room is very cold, they may not communicate with you effectively, whereas you have a conducive environment to effective communication. Also, if you have an open unit such as your ER and some of your triage areas where it's not really any privacy, that kind of environment may not be conducive to effective communication either. Clients in caregiving areas, such as hospitals, of course, and clinics, they will experience less stress, irritability, and fatigue when they remain in relative control of their physical and personal space. So, of course, as the nurse, you want to make sure you are taking heed in their personal space. Okay. Another useful skill is humor. This is healing and can bridge communicative gaps even when the direct communication is feared or offensive. It is recognized as an effective method of helping children and adolescents cope with illness, pain, and hospitalization. Play, I'm sure, is something all of you have heard of, especially for the smaller kids. This is natural childhood behavior, of course. This should be encouraged in healthcare environments and employed as a method of communicating. Using puppets, dolls, and stuffed animals, drawing pictures with crayons and paints, or employing a storytelling approach to give information engages the child. Because play is familiar and a daily form of natural behavior, children do not associate it with less anxiety nor fear. Play helps the child relax and shed inhibitions brought about by the healthcare environments, especially if they're new in the hospital. The nurse who engages in play is likely to be legitimized as someone who can be trusted in communication. Writing and drawing. This is effective with your older school age and adolescents. Writing can include keeping a journal or diary or writing a letter that is not actually being delivered. Drawing can be helpful for younger children since it provides clues to the child's emotional state and their feelings. Evaluating the drawings or having a child tell a story about the drawing allows the nurse a window into the child's inner self and what they're actually perceiving. Okay? When we look at third-party communication, such as toys and dolls, the nurse can promote dialogue with children by using indirect methods such as employing a third party. Here, the nurse directs her attention to the child through a trusted friend, such as a stuffed animal. By doing this, the nurse is taking an interest in the child's normal activity, is employing a stress-reducing communication method to create a therapeutic environment, and is helping the child focus on the content at hand rather than on the anxieties and the fears. Another third-party approach used with older children and adolescents is to attribute feelings or thoughts to other children. This method can be safe, and using group feelings helps a child or adolescent feel comfortable talking to an adult because someone else is talking. The adult is told what the third person thinks without the child or adolescent being held responsible for the statement, since the statement is made by the actual third person. Lastly, we look at storytelling. This is an effective communication strategy nurses may use to promote therapeutic environments with children. Storytelling techniques can be used to establish rapport, assess and help resolve children's anxieties and fears, explain treatments, and procedures, teach health, and prepare for painful or emotional events. For nurses, however, storytelling is a skill, and confidence and competence are gained through use and practice. So basically, this says you will not be a pro the first time you try to tell a story. I know I was not. And what we want to go all the way back to the top and look at observation again. If the child tells you that they are worried about the parent's absence while getting, let's say, immunizations, you want to readdress their fear by reflecting. And a way you could do this is basically say what they said to you. So if they tell you that they're worried about their parents being absent and while they're getting immunizations, a question that you can ask the child is, are you worried? And then that would open up dialogue. This would be reflecting on what the child is actually concerned about. And if the child says yes, then you can go into an open dialogue discussion about why exactly are they worried and what we can do to actually resolve the problem. So you do want to take a look at the communication principles based on developmental levels. And this is in table 13-1 in your text on page 419. Okay, so now let's look at some of the developmental factors that affect communication. This would be the age of the actual child. So first we will look at infants. Of course, infancy is a time when communication is achieved through nonverbal means. However, loud sudden noises may cause startled reactions and crying, while soft, song-like tones delivered in an upbeat tempo may soothe and comfort. Gentle rubbing or patting while securely holding the infant is also a method of communication, pleasure, and security. Infants' responses are nonverbal, such as vocal cues, including crying, cooing, and whining. Body language, such as stiffness or relaxation, arm or leg flexion or extension, pushing away with the hands and the feet against the adult, opening or closing the mouth, and gripping or pushing objects such as rattles or blankets or other nonverbal methods infants use. Infants' expressions of comfort and discomfort become more directly and overtly extant with age. Caregivers soon learn to distinguish their infant's cry and will differentiate the cry of hunger from the cry of pain or anger. Prior to developing stranger anxiety, infants will respond positively to the nurse and other strangers who provide comforting behaviors through feeding, diapering, rocking, and other forms of nonverbal communication. After the onset of stranger anxiety, incorporating the caregiver into the healthcare procedures reduces the infant's discomfort. Whenever the nurse needs to hold or give an infant care, caregivers should, of course, be involved. If this is not possible, the nurse should hold the infant so that the caregiver is in their view. The nurse movement should be firm and gentle, allowing time for the infant to get to know the nurse. And abrupt movements will only increase the nurse's distress. So this should be noted. And these are all ways that a nurse can communicate with an infant. Of course, you want to talk to the caregiver as well because the infant does not understand what you're doing. And when you're communicating with the actual caregiver, you want to teach and allow the caregivers to carry out as many aspects of the child's care as feasible. When we look at toddlers, they continue to experience the world through hearing, seeing, smelling, tasting, and touching. And they remain dependent, of course, on their caregivers. Independence, emergence, and satisfaction is derived from repetition and routine as their environment is explored. Gestures and simple language are used to convey wants and needs. Nurses interacting with toddlers should be observant of the situation surrounding one-word utterances and gestures. They should also learn the words toddlers use for common items or behaviors and use those in conversation. Using play or books to demonstrate or describe activities or procedures immediately before they are to occur is a good way to prepare toddlers for the experience. Being aware of the child's response and approaching the child calmly and positively are, of course, important, since toddlers may withdraw or reject people and/or objects when they are fearful or distressed. As for the preschool years, a child's articulation becomes much clearer. There are improvements in correct grammatical usage, and an expansion of word combining occurs. The child's vocabulary rapidly expands, and the child is able to use words appropriately when the meaning is not fully appreciated. For example, let the child decide whether to have water or a mouthful of jello after their medicine. Nurses need to remind children how to cooperate in an activity or to wait for their turn. Asking the child's cooperation by giving them something to do or hold may engage them cooperatively and allow the procedure to be performed. Using picture books, stuffed animals, puppets, to prepare the child for a procedure will allow the child to experience the procedure in a non-threatening way. When we look at the school age, well, before we look at school age, one more thing on the preschoolers, you want to note that they are egocentric and magical thinking predominates. So these children see things only from their perspective, okay? Allowing preschoolers to touch and manipulate equipment they will see and experience is also essential. Telling preschoolers how it will feel when they come in contact with the equipment, such as cold, warm, pressure, tickles, etc., and how they can behave is also important when it comes to preschooler. When we look at the school-age child, relational experiences expand to include people and environments outside the family and home. They are taught rhymes, chants, and rituals by other children, which can serve as a means of emotional, social control in frightening and confusing contexts. School-age children learn to accept responsibility for their actions. They understand rules, and they become oriented and have increased attention spans. They learn to master concepts. Concrete thinking emerges and predominates. They learn to focus on more than one aspect and explore and consider many alternatives to a problem. So when working with a school-age child, the nurse should spend time with the child to explain treatments and procedures well in advance of the scheduled time. Photographs, books, drawings, or videos may be used to aid understanding and assist in answering any questions. As for the adolescents, they are able to think logically and abstractly, and are able to verbalize and comprehend most adult concepts during this time. They are able to create hypothetical situations and generate explanations for and about situations that they encounter. Privacy and independence are sought in activities and relationships. They need to verbalize what the world should be like in order to analyze their own ideas and come to their position short of idea. Attentiveness and acceptance are necessary. The adolescent should be allowed the freedom to work through issues and should be provided the guidance necessary to develop and decide on a positive course of action. Nurses should communicate support during interactions with adolescents by actively listening without demonstrating surprise, disapproval, or trivialization. The nurse should avoid questioning, giving personal advice, or taking any sides. Short, non-meaning contracts, or contacts, shall I say, may serve as icebreakers and may lead to involved conversations. Nevertheless, you want to be open and direct with the adolescent. You also want to know when communicating with the adolescent, they may or may not want their caregivers around. You have to be conducive to this so that the adolescent will open up to you as the nurse and share things with you that they may not want their parents to actually know. Alright, now we will lastly look at some of the additional considerations when it comes to the child and family communication. One of the biggest ones is cultural impact on communication. Of course, this is important that the nurse, you be culturally sensitive. And if you are not sensitive, it will be viewed as culturally insensitive. You want to know and understand personal and cultural values, beliefs, and that these affect your behavior as the nurse in providing nursing care. You want to learn how to be non-judgmental on cultural values and beliefs for any of the parties that are cared for. You do want to look in your text just briefly on pages 424 and 425 on table 13-2. These are traditional communication patterns and they go over various cultures. So just kind of look at those and see if you have noticed any of those that can place now. And you can take a look at them and see how they will affect you in the future. This can be a good reference guide for when you are going into the hospitals and communicating with these families and the caregivers of these children. If they are of a certain culture, the things that we communicate and find effective, they may not. So those two boxes or those two tables are very helpful. So just take a look at those in your leisure time. And you also want to know that the care planned and implemented with a child or caregiver should be congruent with their values and consistent with their understanding of healthcare. And lastly, communicating with children with special needs. Whenever communicating with these children or these type of children, it is imperative to involve families and to carefully assess the child's skills and abilities. Principles of communicating with children with special needs and their families are the same as those discussed throughout this chapter. As the nurse, you want to note that communicating with children with special needs may prove to be a little difficult and challenging, but it can be done. And this too takes practice. So practice, of course, makes perfect. And that will conclude chapter 13, which is communication with the child and the family. Next, we will move to chapter 16. Let's see. It will review care of the children who are hospitalized. Welcome to chapter 16. Here, we'll talk about care of the children who are hospitalized. Take it upon yourselves to read over or review the history and trends of pediatrics and pediatric nursing. It just gives you a brief overview of where it started and where it's headed in the 21st century. So do take a look at that. We will move forward on to the experiences of children in hospitals and their actual responses. Accidents continue to be the major cause of death in children. Of course, many factors also contribute to the distress of young children during hospitalizations, and existing fears and emotions may be intensified with prolonged hospitalization. Children become anxious and normal fears exacerbated when they think about being in pain, harmed, or mutilated in some way, or being separated from their caregivers. Regardless of the cause of illness or hospitalization, high levels of anxiety are also generated by fears and uncertainties of those responsible for their care. They often perceive a threat to basic needs for love and protection, control and independence, and fulfillment of basic physiological needs. Some fear they may die. The developmental level of children and their perceptions and interpretations of experiences are also important. Their limited life encounters and immature intellectual capacities contribute to difficulty in comprehending what is actually happening. The impact of hospitalization is also affected by the nature and severity of the health problem. The condition and the degree to which activity routines differ from those of everyday life. The primary fears producing stress are lack of control, fear of intrusions and harm, and also separations from the significant persons within their lives. Children fear the unknown and unfamiliar environments and situations where control is difficult to maintain. It is also distressing when language is heard but not really understood. They become distressed when they hear or see other children crying and wonder what may happen to make them cry also. They are also uncertain about how they will fulfill their essential needs if no one is actually nearby. When we look at alleviating the anxieties of children, to lessen the anxieties, it is important to understand the common situations creating distress and then intervene to minimize and eliminate the source of stress. Therefore, it is important to use age-appropriate assessment and pain management to create a pain-free environment. Newer pharmacological methods of effectively preventing and moderating pain are the use of topical anesthetics, such as the Emla cream. That would be one of your topicals. And in the care of neonates, oral glucose pacifiers have been deemed effective in minimizing procedural pain. And they may not come in the form of pacifiers, they may just come in the form of the sucrose water that you've seen or you may have seen within your OB clinicals. This is usually placed on the pacifier or in a syringe, and this usually helps the infant during a painful procedure. Stress point nursing helps children cope by using both procedural information, which is the description of the treatment and sequence of steps, and sensory information, how this might feel. The combination of sensory preparation, topical anesthesia cream, and parental involvement has been shown to be effective in allaying the fears of young children undergoing venipuncture. When children feel they have some level of control in a situation, their apprehensions are, of course, decreased. Reassurance of always being with someone and having a picture of an animal or a cartoon different for each room on the wall inside and outside the room helps the child feel more confident about their place. To strengthen the child's sense of feeling secure, it is important for nurses to let them know when they are leaving for the day. They should say goodbye and tell them the name of their new nurse when they will return. Well, of course, we know that this should be done because of why? They should be doing report at the bedside. So, that is one of the ways that we can decrease some of the anxiety and stress. Make sure you tell the child goodbye, and with the pediatric unit, you'll find yourself doing that quite often because not only will you be saying goodbye to the child themselves, you will also be addressing the caregiver. So it is just common courtesy to introduce yourself and to tell when you are leaving for the day and introduce the new staff member that will be taking over for the plan of care for the child. Here we will look at some major factors in support of coping during illness and hospitalizations. During illness, there are several dominant factors influencing the child's ability to cope and learn to use coping methods. These include inner strengths, talents, and attributes of the child, and external determinants such as the expertise of the nurse, support of the families, and quality of partnership between the nurse and the family, the supportiveness of the environment, and of course the effectiveness of support through play. First, we will look at the inner strengths, talents, and attributes of the child. Remember, each child is unique and has a different temperament, with capacities for managing adverse situations. The temperament of a child and their spirituality may also affect strength in coping. Another strength children have is their ability to form ideas and opinions about nurses and their manner of caring for them. It is helpful to encourage expression of their perceptions about the actions and attributes of the nurse in order to understand what is helpful from the child's point of view. Children's talents also help in coping. Others may have a curiosity about how things work and seek information and opportunities to discuss their condition and experiences or use computers. Some have the kind of personality, charm, and ability to interact and communicate in a way that attracts others to them. Looking at the expertise of the nurse. Expert nurses identify strengths of each child and use them to design, implement, and evaluate nursing care, lend their strengths to children and caregivers, and understand and manage the exigencies of illness successfully. These nurses also understand that the emotional and physical comfort of the nurse is more important than any personal satisfactions gained when children feel or express appreciation for their care. The highest level of skill is attained when nurses accurately identify the immediate needs of the child or family for help, validate the need, use knowledge and all resources available to meet this need, and then evaluate the outcomes. As for support of children by the caregivers, this one is an important one. Support of families is a critical factor in the way children respond to and cope with an illness. The anxieties of caregivers are transmitted to children, and this is an effect on negative post-hospital behavior as well as behavior during the actual hospitalization. Therefore, it is helpful to have a network of friends and family able to offer their resources, time, and assistance. The support of caregivers is dependent upon the empathetic responses, assistance, and cooperation rendered by nurses, physicians, and other family members, as well as their own strengths in managing stressful situations. Of course, the presence of caregivers is of paramount importance, particularly for infants and young children. Yet, the issues surrounding the ability to stay with children and facilities to accommodate caregivers are considered in light of the needs of the family and the child. The critical importance of caregiver presence in the hospital may need to be explained to families because young children are often cared for by others during the day, and the impact of separation in a strange environment may not be fully understood by them. Children of all ages are best able to cope with and learn from experiences with supportive adults by their side. When we look at The relationship between the nurse and the family, the only thing I want you to know is that the quality of collaborative relationships and interactions between the nurses and the caregivers is fundamental to facilitating a child's coping ability. And lastly, we will look at siblings of hospitalized children. This is another factor that we must consider as nurses when it comes to coping. One thing that I want to mention about siblings, those hospitalized children, before visit, they may screen for infectious diseases and their immunization status may be verified. Siblings have fears and fantasies about what is happening to the brother system, and seeing them please helps alleviate concerns, since siblings may fear that they may have caused the illness or that the injury maybe did or did not do. So, the important aspect, the most important one, is if this does come in to visit hospitalized child, if of course they are coughing, sneezing, or have those, as the nurse or per protocol may not perform a screening for communicable disease. They may not allow on the unit. Many pediatric units do not allow children because of the immunosuppression, and of course the common cold for a child can mean life or death for an immunocompromised child. Also, we go to look at support. There could be a child that had a neuroblastoma, which is a type of brain tumor. If they feel helpless, you want to ensure, as the nurse, that you tell them that their presence is very important to the child. And you want to ask if there is some part of the daily care that they would like to partake in. Of course, we're not speaking on the age of the child, but parental vision is needed, and I wouldn't say that it's just for the infant or the toddler or even the preschooler. Your school age and adolescents do need to know that the parents are around. So it is important in some type of terminal illness such that. And you want to make sure you're asking them if they want to participate in the child's plan of care and what part of the child's plan of care would partake in. Is caring for the child and helping the parents with coping and effective communication, all wrapped up into one. Alright, let's look at a couple more factors in support. First, we want to look at the climate of the pediatric unit as a supportive environment. Of course, if you've ever been to a hospital, is it cold or hot? Usually it's freezing. But what's the excuse they usually give you? That it kills all the germs. This can or cannot be true. But as a place of healing, the environment of the pediatric unit should be conducive to feelings of well-being, safety, and, of course, security. Each child should have a place for personal possessions and mementos, including favorite things, regardless of how often worn, such as the skin, well-loved stuffed animal, or the remains of other traditional objects such as blankets or items of clothing. Shoes should be in sight because these are a symbol of mobility and reminders of going home. These are to the children what a hat may be to an elderly gentleman in a similar situation. It's a symbol of life outside of the actual hospital. Every pediatric unit should have a playroom. This should be a safe haven where no painful treatments or scenes are encountered, a place where children are empowered to cope with stressful events on a day-to-day basis. The inclusion of play is so important that children should be brought to the playroom by any means possible. Cars, wagons, beds, wheelchairs, and, when not feasible, play activities should be brought to the bedside, such as giving the child some, let's say, oatmeal, the dry instant oatmeal. This can be given to the child, and the child can use it as sand and they can play with it. And this would be a form of therapeutic play. And this would be for the child that would probably be bedridden and can't get out of the bed or on bed rest after a surgery of some sort. Okay? Play is considered the work of the child, their source of learning, and as such, an integral component of the plan of care for each child. The environment needs to be flexible enough to accommodate the family needs for both visiting and staying throughout the night. And for most pediatric units, depending on the size of the hospital, they may or may not have private rooms. So, this is another issue that you have to address and bring up with the caregivers and the physician, especially if the parents are wanting to room in with the child. Usually, if it's an infant or a smaller child, they try to provide a private room so that the parents can then stay. Now we will look at play as a therapeutic facilitating in coping. And I talked about this just a few seconds ago as far as giving the child some oatmeal to play in the bed if they are on bed rest and things like that. That is a form of therapeutic play. So you want to note that children benefit from the opportunity to engage in play activities to design and promote expression of thoughts and feelings about situations that are difficult to understand or accept. Observation of play helps nurses gain insight about the meaning of behavior and is to guide children in specific situations. Therapeutic play is highly effective. It is a non-directive way of assisting children to use hospital equipment and toys to express reactions to stressful events. This kind of play is stimulated by presenting doll figures such as nurse, doctor, adult, anatomically correct child toys, carrying dolls, etc. A miniature hospital room with these supplies fosters the inclination of children to don the roles of hospital personnel and treat their patients in a safe, simulated setting. Kind of like what we do in the sim lab. The creative arts, including music, drama, poetry, literature, and drawing, are other ways to express emotion and reactions. Play mediates reactions to stress and has been beneficial in physiological benefits as well. Play materials can also be used to encourage strengthening exercises. So, you want to look at the nursing tip on 521 in your text that talks about play as a form of therapy. Play materials can be used to encourage deep breathing exercises postoperatively. For example, a car T blower or a pinwheel are effective alternatives to an incentives barometer, especially when it's to kids. If they think it is neat and fun and exciting, these are ways that we can get them to do the adult activities, but in a childlike manner. Sufficient time each day should be allocated for play experiences, particularly for those immobilized children who are often in a state of waiting and increased vigilance. Creating environments and situations where children laugh and have fun is important to their recovery process. So, when we talk about therapeutic play, if you give a child a syringe, toy, and a doll to exhibit therapeutic play as if they were going to surgery, you as the nurse witness the child sticking the syringe in the eye of the doll and telling her or fussing at the doll that she won't misbehave again, what you need to do, because that wouldn't be looking to you as therapeutic play, that would be kind of disturbing. So, what you would want to do as the nurse, you want to ask the child if they think they are having surgery as a form of punishment. Because depending on the age of they may think they're getting surgery on their eye because they misbehaved at home the week before. So you do want to ask them if they think they're having surgery as a form of punishment, because this, of course, is not the case. And you, as the nurse, would be able to explain that to the child. But by observing their therapeutic play, these are things that we, as the pediatric nurses, can catch. Also, if you witness a 4-year-old drawing a picture that only has a head and a body and legs and no other parts, like they don't have no arms, they don't have no hair, they don't have no clothes on, things like that, you as the nurse just want to appreciate that a 4-year-old often draw people with only 3 or 4 body parts. So of course, if you're counting, and of course they're not going to draw a whole like great big person. They're going to draw stick figures, okay? Let's just get real. It's a 4-year-old. So if you have this stick figure with a big circular head and 1 little stick for a body and then 2 little stick legs, that's 4 parts right there. So they're doing their job, but you may want to ask if, that they're going to lose their arms or something like that. I mean, it would be kind of disturbing, especially if you have not seen it before and you don't really know how to interpret a drawing. You can always ask the child to explain their drawing to you, and this may be helpful. Okay, let's look at preparation and care. So first we want to look at preparation of the children and family for hospitalization. To reduce the potentially adverse effects of hospitalization, preparation should take place prior to admission whenever possible. The primary purpose are to provide information, encourage emotional expression, establish trusting relationships, and teach coping strategies. These goals are met best when the and experiences of the child and honesty and responsiveness to concerns and questions characterize the preparation process. Cognitive development and language skills are also key factors, both in the content and timing of preparation. For planned admissions, the age of the child should be a guide for timing for preparation for hospitalizations or surgery. So for your 1 to 2-year-olds, a day or evening before or day of admission or surgery. For your 2 to 3-year-olds, 2 to 3 days before. 4 to 7-year-olds, 4 to 7 days before. And over 7 years, a few weeks before admission or surgery. Whenever possible, children should have the opportunity to actively participate, such as handling the equipment, such as the blood pressure and stethoscope and IV tubing. Group preparation is often effective for the school-age child. Adolescents need opportunities to explore the meaning and consequences of the experience, in addition to explanations relevant to preparation for surgery or hospitalization. Additionally, they need time to discuss fears, concerns, options, and alternatives. When looking at care of the children during admission to the hospital, the process of admission begins with establishing a helping, trusting relationship with the child and the caregiver. When young children are admitted to the hospital, the nurse should first establish a relationship with the caregiver. Being at eye level and having eye contact while talking to children facilitates positive responses. When children with chronic illnesses are admitted, they need to know how this hospitalization will be different from that of others. Depending on the age of the child and the acuity of the illness at the time of admission, it is helpful to have an orientation to the unit, stressing those areas of greatest relevance. An initial nursing interview with caregivers provides an opportunity to establish helping relationships while learning essential information about the child and family and discovering ways of working together for the benefit of the child. It is also helpful to have a separate interview with the child or adolescent in order to understand their perceptions related to illness and hospitalization. Now, looking at preparation of children and their families for the actual surgery. Generally, children are prepared close to the time of the surgical procedure, and the dialogue, audio, and visual materials should be appropriate for their age and relevant to the child's cognitive development. Of course, you wouldn't go into great length and detail about an appendectomy for a 4-year-old, whereas you would tell a 18-year-old what is actually going on and they would understand. For your 4-year-old, they may want to color in a picture and see a stuffed toy of an appendix. And there you can see the relationship differences. Preparing caregivers also helps improve the child's understanding and ease in asking questions, since family concerns and anxieties strongly influences the child's reaction, preparation, or preoperative experience. Explanations regarding anesthesia need to be carefully considered. For example, the phrase "put to sleep" may be frightening, particularly when this has been used in reference to euthanize a pet. Yeah, so if they just put, SpongeBob the cat down, or they put him to sleep, you sure want to tell the child that they're going to be put to sleep because they think they're going to die. So that would not be okay. To prevent fear associated with perioperative injections, non-injectable medications should be used whenever possible. And transporting young children to the surgical suite, it is unwise to use their crib or bed because doing so may precipitate post-operative fears related to sleep. The young child may reason that if you fall asleep, you may be taken away again, and they are not willing to do that. So the goal for optimal perioperative preparation is to provide and reinforce information for children and caregivers, encourage emotional expression of fear, and teach coping strategies while minimizing intrusive, distressing, and painful procedures. So, let's talk about a few examples. If you are caring for a child who is being admitted, let's say for excessive nausea and vomiting, what you want to remember is that the child may drink lots of fluid, but they may not want to eat. Of course, if you're nauseous, you're not going to want to eat. And most kids may not even want to drink. Of course, we know from all the growth and development that these kids, especially in their younger ages, even in the adolescent stages, are very picky about what they eat. So if they're having excessive nausea and vomiting, note that they will only be drinking lots of fluids, and that'll be fluids of their choice, not so much what we recommend. And as the nurse, do not ever force the child to eat. Next, when completing an admission on a child, you want to ensure that the parents are there or present during the admission assessment. They can help you with anything that you may find on the child, especially if they're not able to communicate with you in your language. Now let's talk about a couple of examples for those going to surgery or after admission to the hospital. So if you have an 8-month-old in the hospital for surgery, you want to prepare them by doing what? Of course, you're going to prepare them by packing their favorite toy. Their favorite toy may be a stuffed animal, it may be a blanket, it may be one of those noise makers of some sort, but you do want to pack their favorite toy. Now, if you have a 4-year-old that is having surgeries, let's say on a specific site, we'll give it a site, we'll say the right leg. Of course, you want to note as the nurse, the child may be shy when it comes to you as the nurse marking the site. Because, of course, remember, we have to have the right site before the surgery. And it is usually marked. Now, in the pediatric area, the sites are usually marked with smiley faces. Of course, we don't put X's on the kids. They contribute this to something bad happening, or it being cut off completely. So if the child shies away from you as the nurse putting the smiley face on the right leg, ask the child, would he or she care for their mother or father to draw a smiley face on their arm or leg for surgery. Oftentimes they will allow the parents to do so because, of course, it's the parent. And you may not have built enough rapport with that 4-year-old, and they may not want you touching them. Looking at a 5-year-old, if they're having surgery, preparation should include also bringing the child's favorite blanket or toy to the hospital. It may also involve purchasing and reading a children's book about hospitalization. You can have the child act out a hospitalization experience with puppets and explain to the child that he or she will have to use the bedpan to go potty or have a catheter in place after the surgery, depending on, what kind of surgery they're having. And if they do not know, what a bedpan or catheter is, then as the nurse, you can try to explain it better or have the parents explain it in more simple terms. If you have a 6-year-old that is having surgery, in preparing him or her mentally, the parent should tell the child about the surgery about 6 days ahead of time so that he or she knows what to expect. At their age, this would be best. If you're prepping them for, let's say you're prepping that same 6-year-old for an emergency surgery, you want to explain to them that you're going to fix the part that hurts. Let's say their emergency surgery is for an appendectomy. What you will tell them as the nurse, so you don't freak them out, because usually if it's an emergency surgery, you don't have adequate time to prepare them and get them ready for what's about to happen. So you would tell them that that the doctor is going to fix the part that hurts down there so it doesn't hurt anymore. You won't say things like, we're going to cut it out and you're going to be in pain. We're not going to tell them things like that. We're just going to tell them in very simple terms that if they're having an emergency surgery such as an appendectomy, that we're going to remove that part that hurts so that it does not hurt anymore. Because of course, if they have an inflamed appendix or a ruptured appendix, trust me, they are in pain. So it is the only type of prep that you can do if they are going to have some type of emergency surgery. So you do want to take heed of how to prepare each age group for surgery and when to prepare them, how far in advance, and your book does a really good job with that. Basically, it's based on the age, of course, and then, of course, what the child will actually need or what will make them more comfortable in the hospital environment. We always want to look at coping mechanisms. So, for our infants, it may be, of course, the parents being there and them having, their favorite blanket. For your, like I said, for your 5-year-old, they may still want their favorite toy or blanket. I would more so they would want their favorite toy. And, they're reading at this point. So reading and talking about what kind of surgery we're going to have, what it is in very simple terms. These kind of things help alleviate the fears and anxieties of the child. Here we will look at coping and communicating. So, facilitating coping with experiences of diagnostic or therapeutic procedures. When children know what to expect, there is a greater potential for maintaining control and mastering fears during uncomfortable and frightening procedures. When caregivers understand the procedure, they are better able to enhance the explanation by making comparisons to previous experiences or using terms most familiar to the child. However, they should not be expected to participate in restraining. Usually, this creates all kinds of distress for the parent if they have to restrain the child. So, if you do need to restrain the child, do ask the assistance of another nurse or your assistive personnel. During procedures, the nurse should consider using distraction techniques to help manage fear, anxiety, and also pain. At the conclusion, treatments offer a simple apology if the child experienced any discomfort or pain. Considerable insight can be gained by asking children and caregivers what could have been done to make the experience easier to manage. When looking at communicating with children and their families, as we just talked about in chapter 13, nurses also need to know the words children commonly use for toileting and vital needs and ways of communicating when they are unable to express themselves verbally, such as with the infant. To refer to the children as kids or to an individual kid as this kid minimizes the dignity of a child. Also, when you're communicating with the children, do not call them honey or sweetie. These can cause children to worry that they have been confused with another child, especially if you have, let's say, 5 pediatric patients and you're calling all of them honey. They may think that you've gotten them confused with another child on the unit. You want to communicate and educate with the parents and families about germs and the spread of infection, and of course, precautions. Especially if you as the nurse witness family members changing diapers, poopy diapers at that, without gloves and without washing their hands. This is the time that you will have to step in and educate them and the caregivers about the spread of germs and infection and the use of standard precautions and how it actually helps the child and themselves from spreading those germs around. Just as with communicating with children and the families, nursing care for the different age groups is different when it comes to caring for these children when they are hospitalized. Let's first look at the special needs of the infant. Gaining a sense of trust is facilitated when needs for bonding, contact, comfort, and nutritional substance are fulfilled, and when rhythmically reciprocal patterns develop. Infants need their primary caregiver during illness. Infants beyond the age of 5 or 6 months are acutely aware of the absence of their primary caregiver and, within a few months, develop stranger anxiety and become fearful of unfamiliar persons. Nurses should be particularly aware of the effects of situations that interfere with the gratification of oral needs, such as oral surgery, vomiting, distasteful medications, withholding foods or fluids, as well as periods of non-oral feedings. When oral satisfaction is threatened, it is difficult for infants to maintain pleasure through sucking, swallowing, digesting, and eliminating. Looking at the direct care of the infant, for consistency, the patterns of care at home are a helpful guide to planning care in the hospital. For first-time mothers of young infants, the nurse is often a model for baby care. Talking to infants slowly, singing lullabies, moving them gently and carefully, and rocking and cuddling are ways to help infants reduce tension. External stimuli such as pictures, mirror, music, and mobiles provide kinds of visual stimuli needed for actual growth. Infant massage is an intervention used by nurses who are prepared to do this technique to soothe infants and provide physical stimulation. Swaddling, by wrapping the infant snugly in a soft blanket, is a practice used by many cultural groups to promote infant comfort and security. Now, you do want to note, they only like swaddling for about 2 weeks, and then they want to get out of there. That's because they're growing at such a rapid rate during that time. They do not want to be all bundled up like they were inside the womb. So, some infants come out and don't like that at all. So, this is used in many healthcare organizations for comfort and security. When looking at the special needs of a toddler, when toddlers are hospitalized, preservation of protective relationships of caregivers continues to be a core part to their healthy growing, development, and healing. Putting diapers on a child who has mastered toileting diminishes the sense of competence and control, so please try not to do that. Of great concern is the actual separation from the caregivers in an unfamiliar environment when family members are not able to stay. When there are short separations, the toddler have become familiar with a primary nurse. Adaptation is then facilitated. It is advised for each child to have a family member present throughout the hospital stay. The primary goals in planning care for the toddler who is hospitalized are sustained child-family bonds, to preserve their sense of autonomy by assuring opportunities to exercise their will, and to strengthen their abilities to mature in cognitive and psychomotor skills. Looking at the effects of prolonged separation on toddlers, if caregivers leave and consistently return after short periods, toddlers can regain security. But if they do not reappear for long periods, the children need them desperately. Separation anxiety poses a serious threat to healthy development. To maintain areas of comfort, the child's bed and playroom should not be used for painful procedures. Treat rooms with supportive persons such as the caregiver and nurse present to provide comforting during and after procedures. This is a better place. Even each day, time should be allocated to providing comfort measures for the child, like rocking or reading to them, to balance the stressors of being hospitalized. So, now look at a couple of examples before we move forward to the preschool care. When looking at the needs of an infant, you want to make sure, first of all, that you have proper identification. Now, all patients have ID bands. When it comes to an infant, you may notice they have multiple ID bands. This is because they're like little Houdinis and they lose them or they slip off, okay? So, making sure as the nurse that you have proper identification for the infant, especially if they're young, such as like a 3-week-old infant. If they have no identification because it slipped off, they got lost in the laundry, as the nurse, you want to get 2 more name bands. Place one on the infant's arm and one on the infant's leg. They will have 2 sites of identification. And usually if the infant is hospitalized, each nurse, each shift is supposed to check and make sure the infant has on both bands. I repeat, the band should be on one leg and one arm. And they are easily to slip off on the arm more so than the leg. Usually the legs are fatter than the arms, so we just want to keep an eye vigilant that our ID bands on our infants are intact. Also, if an infant is hospitalized, You want to make sure that you provide a singular room or a private room for the child and the family, especially if they're going for surgery and the child will be admitted to the hospital and be staying a day or so, or even if the child is in the NICU, the parent should have somewhere to room in. When looking at separation anxiety for a toddler, the nurse should ensure that they tell the parent that they can stay and that visiting as often as possible is a good thing. Now, if the parents cannot stay, you want to encourage them to visit as much as possible. And sometimes it is not feasible for the parents to stay while the toddler is in the hospital. They have to go to work, they have other children to take care of, and so on, so on. So they have other obligations where they cannot solely stay in the hospital 24 hours a day, 7 days a week. So if that's the case, you, as the nurse, want to encourage them to visit as often as possible. This would be the next best thing. Lastly, you want to ensure that the toddler has a safe environment because these are the little walkie-talkie crawlies. You want to ensure that you check the side rails of the crib, that they are in a good raised position, and that they don't need any repairs. Because, like I said, there'll be little Houdinis, they'll get out, they'll go roam, or better yet, if the crib rails are in disarray, they actually may get their heads stuck in between the rails. So we don't want any of that happening. So as the nurse, you want to check the rails and their crib and make sure they're in good repair and that they're raised to the right height. Okay, let's carry on and look at nursing care and guidance for the preschool child. Looking at special needs for the preschool children. Preschoolers learn best through observation and manipulation of objects. Abstractions or things not seen are difficult to understand. They may think the skin holds them together, and any disruption in integrity threatens their sense of being. Seeing blood or taking blood is because it's a symbolic nature. To many children, red is the color of hurting. Children need explanations about their body, organs, and functions, and band-aids to cover any wounds, either by accident or by others, both physical and psychological. Children of this age need caregivers present to protect them from their fears and fantasies and to explain events in terms that they understand. They also need to know the sequence of what is to be done in tests or procedures and to carefully prepare using equipment followed by therapeutic play after stressful events. Even though they explore their environment through intrusion, their greatest fear are related to intrusion into their bodies. Looking at the direct care of these children, this needs to be involved as soon as possible to foster a sense of initiative. They need to be involved in the aspects of their care and have opportunities for choices when applicable. Providing opportunities for playing out stressful events helps avoid feelings of being victimized. Teaching is also a primary intervention in the care of preschoolers. They are usually sociable, and group play and activities are often successful. It is advisable for children to have meals at the table or in an area with other children whenever possible and to maintain mobility. Children need praise for cooperation regardless of their coping abilities. Alright, moving on to the school-age child. During hospitalization, every effort needs to be put forth to help those whose primary focus is school-related to continue to learn and maintain their individual strengths. Some children do not express distress openly, and an outwardly calm child may not be coping successfully. For some school-age children, the ability to master the stress of hospitalization may be a source of accomplishment that increases their confidence in coping and mastering other difficult situations. Continuous, deliberate support, positive relationships, and coaching during stressful times are some measures leading to success in mastering and learning coping skills. When children are hospitalized, the important events in their lives and ongoing problems should be understood, particularly at times of prolonged hospitalization. School age children who develop reading skills benefit from books as well as internet sources to understand their experiences. Now, looking at the adolescent, during this time they develop a sense of identity, and this is the primary task in the mental stage. The concerns and anxieties of adolescents are often masked by an appearance of sophistication, maturity, and what may be described as bravado. Adolescents who are hospitalized adapt when they are with older adolescents in a separate unit where they have privacy and the opportunity to participate in governance of their own spaces. Nurses with special preparation and interest in caring for adolescents are most successful in helping them cope with the exigencies of illness at a time when self-esteem and self-control are major aspects of development. Nothing is more important than talking to adolescents and listening carefully to what they say and how they say it. Their needs for uninterrupted time is very important to the process of developing coping skills. Adolescents may develop crushes on nurses as a part of the process of developing a sense of identity and testing oneself in the formation of sexual identity. Make sure you do not allow this to happen. Do not cross those professional boundaries. So, like I said, in these situations, it is helpful to be direct and honest in setting boundaries while understanding the need for working out relationships with others. Finishing up this chapter, we will look at the expectations and some of the special considerations when it comes to the caring for the child who is hospitalized. Let's first look at expectations and needs of the caregivers during hospitalization of children. During the crisis of hospitalization, caregivers need to have an accurate and timely information to trust the competence of physicians and nurses and to know their child is comfortable and free of pain. Caregivers also need to feel cared for in the social sense in order to feel more positive about their experiences and better able to cope. In situations where children are hospitalized for extended periods of time, support groups for caregivers are an effective way of creating an environment to express concerns and strengthen coping abilities. We will skip over children with chronic illnesses. The only thing I do want to point out there is that caregivers, these children are often experts about the disease process and treatments on a day-to-day basis, and the children themselves become increasingly competent in self-care as they get older. So we don't want to not listen to the parents when they are trying to tell us as nurses about the child's illness, because we have to remember they've been living with this child since they were born and probably dealing with this illness for far more time than we have encountered. Looking at emergency care, in emergency care, pediatric nurses need to be highly skilled in immediate interventions. Because children are different from adults, both anatomically and physiologically, it is critically important to understand the nature of the differences that affect successful treatment. You can review pediatric ICU and home care. It just basically goes over what is involved for those two units, or for that unit and the home care aspect. We will look at the discharge and post-hospital effects. Throughout hospitalization, children and caregivers need to be prepared for discharge, post-hospital or post-surgical care, and the effects of this experience. This often involves extensive teaching and preparation for transition, especially when there has been prolonged hospitalization, painful treatments and procedures, or changes in the body image. The kind of preparation is dependent on the continued needs of the child and family for care and support in coping with fears and anxieties. Changes in behavior post-hospitalization are most evident in children between 6 months and 6 years of age. Most changes in behavior occur after 2 to 3 days of hospitalization because children encounter multiple tests, treatments, and separations from those who provide their primary support. This is also a time when caregivers are anxious and may be less available to give the psychological support that the child needs. As the time for discharge approaches, caregivers may feel relief about reassuming family life, yet also feel apprehensive about caring for the child at home. Looking at preparation for clinical nursing in the care of children and their families, the only thing I want to make note of is that the predominant goal is to identify and preserve the strengths of children while trying to enhance their growth in the midst of stress and intrusions into their body space and their very being. Of course, to do this successfully takes an understanding of the lives of the individual children and their families, and the courage and commitment to accurately discern and meet the emerging needs. And that will conclude chapter 16, which is care of the child who is hospitalized. So next chapter we will go into is chapter 20, which will cover loss and bereavement. Alright, here we go. Chapter 20, loss and bereavement. This will be the last chapter for this lecture. And let's jump right on into it. Children experience loss and bereavement through a myriad of situations that are not related to the death of a person. Today's children are coping with various types of losses at much earlier ages. These earlier experiences are important to help individuals' ability to cope with loss later in the adult life. Let's look at some situations that lead to loss. Relocation. The effect of relocation may initiate feelings of anxiety and loss for children. Relocation may be a positive or negative experience based on the circumstances. Relocation for adults may mean a job, better finances, or a larger living space. It may be the result of need to be close to elderly parents, or may be the result of disruption in families such as divorce. However, for young children, such a move may be seen as a loss of comfortable and familiar things, people, and surroundings. Moving to a new school or even starting a new grade may trigger feelings of anxiety and loss. Loss of a possession. Children at an early age develop attachments to objects such as toys and items of clothing. Such objects may bring about a sense of relaxation, security, and comfort. The loss of a treasure can cause feelings of anxiety in young children and may be a child's initial experience with loss and separation. Pet loss. Most pet owners view their pets as members of the family and attribute human characteristics to them. Yes, I agree, because my pet is like my son, and the only good thing is I could lock him in a cage, and I have a stroller for him and everything. So he's like a member of the family. So if I had a child, my child would probably be devastated once the pet died. But many relationships between pets and children are positive. They learn to share, care, and be empathetic, and to communicate socially. Because children view pets as friends, the loss of the pet, which is death, loss from running away or being stolen, may be the child's first real experience with loss, separation, and grieving. It is best to be honest about death of a pet, and that honoring the pet's life is, of course, important. Parental separation or divorce. Of course, divorce is an extremely stressful event in the life of the family and is the leading cause of separation by families. Two major factors in children's reactions to loss are the child's age at the time of the loss and the child's cognitive development. Children's adjustment to divorce is related to many interconnected factors such as age at the time of divorce, parents' well-being, psychosocial state, reasons for the divorce, and child support and child custody issues. The child often assumes he or she did something wrong. This in turn causes the child to fear abandonment by the custodial parent. These children may temporarily lose any independence recently acquired and return to bedwetting, thumb sucking, or even bottle feeding. Preschoolers may experience nightmares or sleep disturbances, and their play may become aggressive as they attempt to act out their feelings of confusion. School-age children may believe their parents' emotional distress is related to how they have been behaving and can perceive the divorce as a rejection, resulting in feelings of guilt. Fear of being replaced may exist with low self-esteem. Children in this age group may have fantasies of reunification of the parents and the family. These children may also manifest their distress in anger, somatic complaints, and social withdrawal. Purification is also common in adolescence, especially when daily activities of the home are neglected and the adolescent must take on the role of the absent parent by preparing meals or doing laundry. Antisocial behavior such as delinquency, becoming physically violent, smoking, alcohol abuse, and truancy may occur. For some adolescents, school may be a refuge from the turmoil at home, and they may spend a lot of their energy in school activities to avoid thinking about the situation at home. So, one quick thing that I do want to talk about is the first step in being an effective nurse with a dying child is to first identify your own reactions and feelings about death. If you do not do that, then you cannot be an effective nurse for the child nor the caregiver. Now let's briefly look at the children's awareness of death. Information once shielded from the young children, such as death and violence, is now readily discussed in the playgrounds, schoolyards, and neighborhoods. This is something that we want to make the caregivers aware of, that they are not oblivious to the fact that death does exist, no matter what the age. Children's understanding of the concept of death takes place over time. When we're talking to children about death, if you're in the home, allow the child to grieve. Provide the child with quiet time according to the child's age and development. Communicate how you feel. Provide opportunities for all members of the family to share their grief. And provide avenues for the child to express feelings such as drawing, singing, or writing a poem or letter. Now, when we talk about death in the school, you want to provide opportunities for children to talk about their feelings, offer supportive counseling, and of course provide books and resources. Literature on children's understanding of death reveals on average that children under the age of 4 have little to no understanding of the concept of death. So you want to take a look in your text on page 63 at table 20-1, which goes over the theoretical basis of understanding the concept of death. This is more for Piaget's theory, and it goes over the age groups and how they understand death. So mainly in this table, you want to look at the ages and their understanding of death. So I know your book says under the age of 4 have little to no understanding. Well, of course, from 0 to 2, they have no clue what death actually is. From 2 to 4, it's reversible, it's temporary. So they know it exists, but they think that the person may or may not come back. Okay? And then from ages 5 to 6, they think that it's avoidable, that they do not have to die. And then from 7 to 11, that is a casualty. Okay, and then from 12 to 17 is selective universality. Does not include self. So these are the go-getters, the risk-takers, and they believe that death can happen to everyone else and it won't happen to them. So they want to do all of these things. Ride without a helmet, drive off of cliffs, dive, into the rocks. They want to do crazy things, and that's more so for your adolescents. Crazy, crazy people. Although adolescents are capable of understanding and conceptualizing death, like I said, as a permanent and universal, often there is an exclusion of self, okay, from this concept. In other words, it won't happen to them. That's really what they believe. So let's briefly look at grief and bereavement. Grief is an individual's response to loss, and it is viewed as a natural and healthy reaction and an ongoing process across development. It is a complex range of feelings, cognitions, and behaviors that an individual has in reaction to a loss. Bereavement is seen as an adaptation to a loss, and mourning is the process one goes through on his or her own way to adaptation. To clarify these terms, one can describe grief as the reaction an individual has to loss, and bereavement as the behaviors one exhibits after loss. Each person's response to loss and bereavement is influenced by cognitive development, age of the individual, religious and cultural influences, as well as personal and family experiences. Looking at grieving and mourning, grieving an individual's reaction to loss is viewed as a passage of time through which the individual may progress at different rates, sometimes moving in and out of various stages. I'm sure you remember them probably from way back when in psychology, and you may even talk about them again or revisit them again in mental health. You have denial, anger, bargaining, depression, and lastly, acceptance. You want to look at the four major tasks: accept the reality of a loss, experience the pain or emotional aspects of the loss. Task 3, adjust to an environment in which the deceased is missing. And the fourth task is relocate the dead person's memory within one's life and find ways to memorialize the person. You also want to review the stages of grief, which can be found in your text on page 634 in table 20-2. And that is more of a Kubler-Ross process, and it goes through those 5 stages and responses to the loss from the separation of or divorce and then death. So that's a very good chart there in your text. And you also want to pay attention to box 20-2, page 635, which are the factors influencing children's reaction to loss. Now let's look at some examples. Depression, the depression stage of anticipatory grief includes if they say, I used to love playing board games with my son, now that just makes me sad. That's the depression stage. They know that their son is terminally ill or has an end-stage disease, and they're just, reflecting on what they used to do with their son and will not be able to do after a while. If parents just got a new terminally ill diagnosed child, so if their child was basically diagnosed with a terminal illness or even just a chronic condition or an end-stage disease, as the nurse, you want to provide non-judgmental support to the family. Also, you want to reassure the parents that their reactions are normal during this stage in the grieving process. They'll go through denial where they cannot believe that this is happening to them. Why is it happening to them? They may ask for a retest and, trying to then bargain. That's after they've gone through the anger, but they may bargain and then go back to denial. So like your text says, they can go in and out of these stages, okay? And if the nurse is failing. If you, as the nurse, or you witness a nurse failing to enter children's rooms, and it is children who are terminally ill, if you witness him or her only going into the room to pass meds or to do an assessment, he or she may then be going through the grieving process and may be in denial. So it's not only the caregivers that we look at and assess, we also assess ourselves as nurses, because it is not uncalled for a nurse to get attached to a patient or patients or their caregivers and really not want to accept the fact that they have this terminal illness. And I've seen it multiple times where children come in for one thing and they are then diagnosed days later with a terminal illness, an end-stage disease, a chronic condition, or something of that nature. And it really does the nurses and the other clinical assistive staff on the unit, because they have gotten to know and build a rapport with these children. Here we will look at the understanding that the child has of death and how they react. Children may have long fits when they are overcome with grief, which is then followed by an interval when they do not seem to be affected at all by the loss. This is normal. Nurses must help grieving caregivers understand the child's behavior is a normal process of grieving, since children do not grieve the same as adults, and the manner in which the child responds is highly influenced by socialization. Children's reactions to loss, whether it be due to separation or death, are also related to their personality, family, cultural, and religious affiliation, age, and cognitive development. Although young children may have little comprehension of death and separation, they manifest behaviors indicative of what they are sensing. Preschool children often manifest sleep disturbances, including nightmares, bedwetting, or fear of falling asleep. They may also determine clinging behaviors such as holding on to caregivers, crying, or not wanting to be left alone or separated from loved ones. Bereaved and grieving adults may be angry and depressed, but not share their feelings with relatives and keep their feelings hidden inside. The adolescent may also act out angry feelings in activities such as consuming alcohol, using drugs, dropping or staying out of school, isolating themselves from peers, and severing recently formed relationships. Now, when we look at the child's responses to death of a caregiver is the first one that we'll look at. The death of a parent is extremely traumatic experience and a major crisis in the life of a child. The death of a parent is conscious in the home and family change the very core of the child's existence. Children's reaction to loss of a parent is often influenced by how the surviving parent and other adult family members react to the loss. When surviving parent expresses feelings, he grieves and is able to spend time talking to the children about the loss in a positive and loving manner. Children may openly express their feelings in age-appropriate ways as well. The death of the mother may bring about change in the roles of family members. Routine schedules and responsibilities may, of course, change. Although children grieve differently than adults, they also need support, encouragement, a listening ear, a lap or shoulder arms to hold them. When we look at death of a sibling, this is usually due to an illness or increase in sudden or traumatic death. However, often following the death of a child, surviving siblings are overlooked, as support is generally provided to the grieving parents, as if the sibling does not grieve or the children do not grieve. Siblings should be allowed to grieve and be supported in their grief. The closer the relation was before death, the more behavior problems that the surviving siblings demonstrate afterward. When a child dies, the surviving sibling loses not only a brother or a sister, but the functional loss of the grieving parent, since frequently parents are likely to experience their own difficulties coping with loss, which impairs their ability to parent or assist their children. After the death of a sibling, surviving siblings may experience a sense of increased vulnerability, anger at the parents for not protecting the deceased, or on the other hand, protectiveness of the parents. Therefore, it is important for nurses to understand, because grieving parents may be emotionally unavailable to the surviving children, and because support is generally directed toward the parents, siblings are often most neglected family members when a child dies, and this is not right. When we look at disaster or traumatic events, the rise in violent crimes committed by children in generally safe environments such as schools, playgrounds, and homes has propelled this generation of children to a new level and kind of unprecedented risk. The effects of the disaster or traumatic events may have long-term consequences, interfering with the child's ability to engage in productive behavior and adequately function socially, academically, and of course, professionally. If the child has died and they do have a sibling, please, as the nurse, you want to assess the child's feelings about the death of the sibling who actually died. We do not want to neglect the child that is left behind. Remember the saying, no child left behind? I know that applies to education, but we want to apply it to this theory as well, or this concept as well. When a sibling dies, we need to assess the child and not just be there and assess and educate and be there for the parents. We need to be there for the child as well. Now that we've looked at the child's reaction to loss and death, we'll look at the family reaction to death. First, we'll look at loss of a newborn. Loss of a newborn remains a stressful and traumatic event for parents, families, nurses, and others, regardless of the reason that the infant died. When preparing the deceased newborn for viewing by the parents, it is important that the newborn be washed appropriately. This helps the parents see their deceased newborn as a living being. Therefore, the deceased newborn should be placed in a bassinet, fully clothed and swaddled in a blanket. Chairs should be provided. Parents should be allowed to hold the baby and to stay as long as they choose. A nurse should present the baby to the parents as if the newborn were alive. And this happens when you have a fetal demise. I wouldn't say the good thing. The thing that we do want to do is make sure that the parents are able to spend adequate time with the child. And we do dress the child, we put the child in a crib, and we make sure that all the staff members know that it is a fetal demise. Now, we want to look at how much should a child be told when someone dies. It is imperative the interdisciplinary team and caregivers discuss what and how much information the child should receive. Also, there should be discussions about the information given to siblings. Usually, children can sense something is wrong by the way the adults treat them. Since there is often a tendency to walk away from the child when issues are being discussed, this behavior suggests to the child that something, of course, is wrong. Therefore, in efforts to protect children from knowing they are ill, nonverbal behaviors may alert the child that something is wrong and may cause increased anxiety. What exactly should the child be told? Children as early as preschool age should be told when they are ill. Information should be concise, clear, and, of course, simple. Today, children have many avenues to obtain information, such as books, television, and, of course, the internet. However, not all information is accurate. Therefore, it is important for family and healthcare providers to collaborate to provide the appropriate and accurate information. Who should tell the child? There is no real rule that exists on who should inform the child about their illness, but a small group of individuals who will be primary care providers are the best. The small group may consist of parents or caregivers, a nurse, and a physician or primary health care provider. A number of caring and loving individuals with whom the child has a trusting relationship, as well as members of the interdisciplinary team with whom the relationship will or has been developed, help the child maintain a sense of security, love, and belonging. Nurses can play a pivotal role in maintaining a sense of security and a trusting relationship with the ill child. Finishing up this chapter on loss and bereavement, we will look at and discuss briefly a few other considerations when it comes to this topic. Decisions about hospice is one of them. Children's hospice care is a growing alternative for hospital care for the dying child in the family, and this incorporates a holistic approach providing psychosocial, spiritual, and physical support for the child and the family. Hospice services also provide respite care to allow family members to take a break or time off for themselves before reassuming primary care for the child. When we look at organ donation, you want to note from previous chapters you do need a consent, but this is a very sensitive and uncomfortable topic for many healthcare providers since possible hope for life saving for one person means death to another, and an awkward time for the healthcare providers, which actions seem cruelly intrusive or on a grieving family. Nurses caring for the dying child are aware of the total plan of care for their clients and a pivotal position to evaluate family concerns about the issue and provide avenues for family members to openly discuss their concerns with the transplant team. When we look at autopsy, the decision to perform an autopsy is a requirement of law when the death is caused by unnatural causes such as murder or suicide. It occurs within 24 hours of hospitalization, or if the death occurs at or in an institution where the person has not been under the care of a healthcare provider. Nurses can only emphasize to the family the decision to perform the autopsy is not a decision based on hospital policy, but a requirement of state law. If a child does not have an autopsy, it may be important for the family to see the child after the procedure, and this information should be obtained prior to the autopsy being performed. And let's see, we'll look at care for nurses working with the terminally ill child. At times, nurses who are experiencing feelings for caring for the dying or terminally ill child begin to question the technology, the profession, and even their faith. During this time, nurses are not able to appropriately attend to the needs of the dying child or the family and must come to terms with their own about death and dying and must allow themselves to grieve so that they can help others. Nurses caring for the terminally ill child and their families must actively focus on promoting their own health. The nurse providing care for the terminally ill child is involved in caring for physical, psychosocial, and spiritual needs. The child may be alert and responsive at some times and at other times may be weak and uncomfortable. The plan of care should not only be visualized and realistic, but it also based on immediate needs of the child. When the terminally ill child is dying, the nurse must cope with the additional needs of the child and the family. Responding to the physiological needs of the dying child. A primary goal at this time is keeping the child, of course, comfortable and pain-free. Maintaining a clean environment, providing hair and oral care, and other aspects of daily hygiene can help maintain the dignity and human experience and promote psychological integrity for the family. Nurses must continue to provide care to these clients with the same enthusiasm, even when they question the purpose of their interventions. When providing care to the terminally ill children, nurses must, of course, revisit their own thoughts and feelings about dying and death, understand the process of grieving, talk to the children in age-appropriate language, help children verbalize their feelings about death and dying, be consistent in the care that is provided, and, of course, be honest in the discussions. During the time of death, nurses must also uphold and respect the cultural and religious beliefs and rituals of the family. And lastly, but not least, attendance of nursing staff at funerals. Of course, Some say no, some say it's fine. Although there is no hard and fast rule, it may motivate nurses to acknowledge their loss and to put closure to the experience. At times, the request for the attendance of the nursing staff at the funeral is made by the family through announcement of funeral arrangements sent to the unit. Nurses need to determine for themselves on an individual basis what works best for them. So it is no real true rule on whether the nurse should or should not attend the funeral, but the nurse must make their own decision as to what's best for them. If that is what they need to do as far as the grieving process and for closure, then by all means they are encouraged to go. Alrighty then, I'm sure you guys are excited to come to the end of this lecture as it has been long. It has included 3 chapters, 13, 16, and 20. We have covered communication, hospitalized child, and loss and bereavement. Now, this will also be on your exam along with the last 2 chapters of growth and development, which covered the school-age child and the adolescent. Please feel free to write any questions, comments, or concerns, or voice them in class upon your next course. And good luck and have fun studying.